Good morning. Today's August 6th. We have hospital budget hearings today, and this morning we have a presentation on a mid-year adjustment request made by UVM and also Central Vermont Medical Center. We're going to hear the UVM presentation first, and I'll turn it to our counsel, Mark Hengstler, to provide an overview of the law and the settlement agreement that is pertinent to this presentation, and then he will turn it to UVM for their presentation. Thank you.
Thanks, Chair Foster. Mark Hengstler, staff attorney for the Care Board. I think I have 3 items. The first I'll just get out of the way is a procedural matter. So today the board is hearing from both UVMMC and CVMC on proposed reductions to rates for FY25 in order to comply with FY25 budget orders. I want to note for the record that Member Merman has recused himself from any deliberations as to CVMC. These proposals between UVMMC and CVMC are very similar. For that reason, the board is reviewing these together. It would be difficult to talk about these segmented from one another. So Member Merman, who has recused himself from CVMC, will ask any questions regarding UVMMC or that might generally apply to both, but will not ask questions directly of CVMC leadership. And this has been discussed and cleared by the Health Networks Council. So just wanted to get that on the record for how we're dealing with that. Separately, what I want to do is give a public overview of the law that applies here and how these 2 requests, or I guess the UVM request in particular, ties to the settlement agreement that was before the board earlier this spring. What I'm going to do is share my screen, and I'm going to start with the board's policy on budget enforcement and talk about that. That budget enforcement policy applies to all hospitals. So it applies both to CVMC and to UVM Medical Center. And then second, I'm going to talk about the settlement agreement, which only here applies to UVM Medical Center. Just give me a moment while I share my screen. All right. Can you see the policy on budget enforcement?
Yes.
Great. So starting point is that each year the board establishes a budget for each hospital, which includes a net patient revenue cap. That cap is a cap. It's not a guarantee of revenue that the hospital will bring in. It is a limit, and the board's policy on enforcing that cap is outlined in its policy on hospital budget enforcement. And this policy, boiled down, states something quite simple, which is that these net patient revenue caps, as ordered, may be enforced, and that the board will review any hospital whose year-end net patient revenue exceeds its cap by 1% or more. So the question for the board in whether it considers enforcement is first, whether a hospital has exceeded its NPR cap by 1% or more. And then second, the board holds a hearing on enforcement, potential enforcement, considers factors that are outlined in GMCB Rule 3. The hospital can speak to those factors and explain reasons that it might seek a different outcome than enforcement of the overage, and then the board votes. We are not here to discuss budget enforcement today. There's been no notice of an enforcement vote. The board is not voting to enforce today, but what's being discussed today is UVM Medical Center and CVMC's actions to comply with the board's FY25 budget orders. If the hospital's actions are insufficient to address overages, then we would turn to the board's budget enforcement policy, and the board would consider whether to hold any hearing on potential enforcement. So this applies again to both hospitals. Now I'm going to turn to the settlement agreement executed between the Health Network, UVM Medical Center, and the board. So as a reminder, this was a settlement agreement which did a number of things, but it was designed to at the highest level, settle pending litigation that UVM Medical Center had brought to both Vermont Superior Court and the Supreme Court, and separately to outline a series of obligations of both the board and UVM for the purpose of moving forward in dealing with revenue issues. This agreement is broken into parts. So there's a part on UVM Health Network and Medical Center obligations, a part on board obligations, a part on a work group and consultant process, and then a section that deals with how the parties deal with any potential breach of the settlement agreement. So I'm going to start with section 1. Again, this applies to UVM Medical Center. And in particular, this applies, what applies is section 1D. And I'm going to read section 1D. The section says that after the second quarter of FY25, UVM Medical Center will seek a mid-year reduction to its FY25 commercial rate growth if necessary to ensure compliance with the GMCB's FY25 budget order. I want to point out two things with this language. The first is that the medical center was obligated to seek a mid-year reduction if necessary after second quarter. Second quarter would have been end of March of 25. I believe that UVM submitted this request in that we're looking at today, this rate reduction request in July. And the second piece is that the purpose of this rate reduction is to ensure compliance with the board's FY25 budget order. Again, each budget order has a net patient revenue cap. The enforcement policy concerns any overage greater than 1% on that cap. The language in this section is different. This is not saying that the hospital needs to ensure compliance with 1% over the cap, right? Not needs to avoid enforcement. That's not what it says. It says ensure compliance with the budget order. I believe the figure, and Matt Sutter's team can confirm if I get this wrong, so please do step in. I believe that the total figure for UVM Medical Center's FY25 net patient revenue cap was 1.924 billion. So that would be the figure that UVM would need to be under or at in order to ensure compliance with its budget order. So that's the piece that applies to UVM Medical Center, but not to CVMC. So what happens if UVM does not comply with this provision? That is dealt with in the settlement agreement. So I'm going to scroll down to section 4, which is a general provision section. I'm going to read subsection C. So this section is about what happens if a party does not comply with the settlement agreement for a reason that is different than impossibility. This agreement is governed by Vermont law. Any disputes under the agreement will be adjudicated by the Vermont Superior Court. If any party believes the other is in breach of its obligations under the agreement, it will provide the other with written notice of the alleged breach, and the other party will have 30 days to cure the alleged breach prior to either party initiating legal action to address it. During that 30-day period, the parties will meet and confer in an effort to resolve their dispute. In the event either party is determined by the court to be in breach of its obligations under the agreement, the non-breaching party may, but need not, terminate the agreement, and upon termination, each party will have the same rights it would have had absent the agreement, provided, however, that in the event of any subsequent GMCB budget enforcement action with respect to UVM's FY24 overage, which was waived for enforcement in this agreement, the remedy for that overage will be limited to the total amount of the NPR overage minus any money already expended pursuant to the agreement. I can speak more in detail later if board members or public have questions about what that section means. It's a bit dense. So I just wanted to point to those two. And I guess the last thing that I'll add is that this request from UVM Medical Center and CVMC was couched as both a request, a UVM, a attempt to comply with the settlement agreement, and separately as a request for a adjustment to the FY25 budget. So both hospitals explained that this was an application for adjustment to the FY25 budget. I do just want to speak very briefly to that. The board does have a section in its hospital budget review statute at 18 VSA 9456 F1, which states that a hospital may come in and apply for an adjustment to its budget if upon a showing of need based on exceptional or unforeseen circumstances. I just want to point out that although a board vote is scheduled today, that section of the statute is really not designed, as far as I can read, to line up with the hospital's requests today. In the past, hospitals have used that section to come in and request apply for adjustment, meaning apply for a modification to their budget order. Here, the hospitals are proposing a temporary reduction to rates for a particular line of services that would lower projected revenue for FY25. The board sets rate caps in orders, but it doesn't set rates in orders. So hospitals have the ability, without any adjustment to their budget orders, to lower rates as needed to comply with the budget orders. So I just want to point out that if the hospitals are planning or have already lowered rates for certain services in an attempt to comply with the budget order, that is good in terms of compliance with the budget order, but it does not necessitate a board vote to modify the budget order, which again sets a cap on rates. It does not set the rates themselves. So with that, I'm going to turn to swearing in any leadership of UVM who intend to speak today. What I'll do is I'll read the oath, and I'll ask that anybody planning to speak for UVM individually state your name and then affirm the oath. That way we have on the record the people who are speaking for UVM as well. All right, so for all those who are testifying today, do you solemnly affirm that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth under the pains and penalties of perjury?
I do.
I do. I do.
I do.
All right, I'm going to turn it over to UVM for its presentation.
Thank you. Chair Foster, members of the board, thank you for the opportunity to be here today. We're here today before you to discuss our proposal to reduce the rates we charge commercial insurers mid-year, which we believe is an important step toward improving affordability for Vermonters while keeping our hospitals financially sustainable. As you've seen in our filing, we've provided a lot of detail already. Today, our goal is to briefly explain why we believe this step is necessary, and then spend as much time as possible answering your questions. After our remarks, Ian and I will turn it over to Judy, Kim, and Rick to review the data and share an update on where our hospitals are likely to end the fiscal year. Through this mid-year proposal, University of Vermont Medical Center is asking to reduce what we charge Blue Cross Blue Shield of Vermont, MVP, and Cigna by about $20 million from what our current rates would allow. We made this request because we understand the very real crisis of Vermont healthcare affordability that many Vermonters face. We recognize our responsibility as the state's largest healthcare provider to help address the crisis. We share your sense of urgency to act now, mid-year, rather than waiting until January. We recognize this proposal does not address the entire NPR overage. Our focus here is on commercial rates, returning all unbudgeted revenue to the three major payers serving Vermont. We've had ongoing conversations with several of you and the independent board liaison about this distinction since our settlement agreement in April. We believe this approach reflects the shared goal we all care deeply about: strengthening stability in the commercial insurance market in Vermont. At the same time, it preserves the Medicare and Medicaid reimbursement that is critical to our financial sustainability. We know this request will not go as far as some hoped, or even as far as we discussed earlier this year. But we do see it as the most balanced and responsible way forward together as we head into uncertainty with Medicaid funding. This approach also positions us to have this discussion, which we'll have with you next week on our FY26 budget. We believe this proposal strikes the right balance, addressing where the affordability crisis is most acute while keeping our healthcare delivery system sustainable for ongoing changes. I look forward to answering your questions. I would comment now that our slides actually have CVMC and UVM data together. So if it's okay with you, Chair Foster, I'll let Anna give her opening remarks. And then as we go through the financial data, you can ask how you want. Is that okay with you?
Yeah, that's totally fine. I apologize. I should have checked in or had someone check in on my process first. Ms. Noonan, have you and your team been sworn in too? I think you probably have to be before you testify. You did?
Yes.
Okay.
Yes,
Okay.
we were. Thank you.
Yeah, totally fine.
All right, great. Well, good morning and thank you, Steve, for that, your opening remarks. Chair Foster, members of the board, thanks for the opportunity to speak with you today. Taken together, this mid-year rate adjustment proposal, our FY26 budget submission, and our FY24 adjustment reflect, we think, important steps towards affordability while still ensuring Central Vermont Medical Center's long-term sustainability. Like UVMMC, CVMC is committed to taking meaningful action to address affordability now, rather than waiting until fiscal year 26 rates take effect. That's why we're proposing to reduce commercial rates by about $6 million for Blue Cross Blue Shield of Vermont, MVP, and Cigna mid-year to provide relief sooner. Central Vermont Medical Center has worked hard to improve efficiency and expand access to meet the healthcare needs of our community. In FY24, we achieved a positive margin of 1.7%, our first in 8 years, following 7 consecutive years of negative operating margins. Those ranged between a negative 0.6% to a negative 6.5%. CVMC must remain financially stable so we can continue to provide the care and services our community relies on. At the same time, we share the urgency to address affordability immediately. That's why our proposal focuses on the anticipated commercial overage, an area where we can take meaningful action together. CVMC will be here to take care of every patient regardless of the payer. Preserving federal reimbursement for Medicare and Medicaid is critical to ensuring that we remain available for the most vulnerable patients that we serve. In closing my opening remarks, this proposal focuses on the portion of our revenue where together we can make the most immediate impact. It returns unbudgeted revenue from those 3 commercial payers now in the form of reduced rates for the remainder of the year. We respectfully propose that we move forward with this important step towards improving affordability without compromising CVMC's long-term ability to care for our communities. Like Steve, I look forward to answering your questions, but I think Rick Vincent would like to also provide some opening remarks. Thank you.
Morning, board members. I have just a few slides. As Dr. Leffler said, they're combined with UVM Medical Center and CVMC, so we can come back to them depending on when we want to have those discussions. So I'll go through those slides really quickly and then open it up for questions. So just to summarize, we just wanted to highlight a few things from the proposal. This is just to summarize what our proposal does. As Dr. Leffler and Anna stated, it focuses on the major commercial category as that directly impacts affordability and rate payers in our business community. For UVM Medical Center, it was $20 million. For CVMC, it was $6 million, and that was based on year-to-date March. Just one comment in terms of when the proposal was submitted, we definitely were planning on submitting this proposal in essentially the early May timeframe. The delay was really due to trying to understand exactly what was happening with the drug legislation and how that might impact our budgets going forward in our FY25. So I just want to make that comment. That's why we didn't change any of the numbers in our proposal. It is based on the year-to-date March numbers that we had at the time. The next point is just depending on exactly when these rate reductions are implemented, a portion would impact FY25, and then a portion would impact FY26. And we did assume that these rate changes would go into effect on August 1st. So our FY26 budget includes that portion that would be in FY26. But the key here is that we would ensure that the rate reductions would all accrue to the major commercial payers before the end of the calendar year to align with their contract year. Next slide, Jen. This is to pull out one of the pieces from the proposal and to highlight that not much has changed here in terms of the breakdown of the variance from March. The utilization variance, or how these categories are calculated, is the same way that it's done for the bridges file that's part of our Green Mountain Care Board process and our rate decomp file. If the board needs more detail on exactly what makes up that utilization, we're happy to provide more detail there. Next slide, Jen. For this, we thought the board might be interested in just seeing how things have changed from March. So the first set of columns is from our proposal, just highlighting where total NPR was at in March, and using just a straight annualization of those March results, assuming that same trend would continue for the rest of the year. We added some June data just so the board can see if there's been a change in that trend with 3 more months of data. So you can see for the UVM Medical Center, which is the top chart there has been a little bit of a decline on a pure annualized basis in terms of total net patient revenue. So in March, we were annualizing to have a variance of $49.5 million, and that's now down to $46.7 million. When you look at the commercial, same thing, that trend has come down a little bit, where that variance is now projected to be a little bit less, again, using just pure annualized figures with 3 more months of data. We then also just added a 1% adjustment for year end so that you can see the trends there. For CVMC at the bottom, similar, so the total net patient revenue with 3 more months of data has decreased slightly, but the total major commercial category has increased a little bit. Next slide, Jen. And then finally, just based on some email exchange with Matt yesterday, we thought we'd put this slide in here because I think the board and the staff are more focused on exactly what we projected in our budget filing. So we thought, since our proposal was really just doing a very simple annualization, that we'd take a look at the numbers as well for the board, looking at the projection that we submitted in our FY26 budget filing. So that's the first column that you see there, using the $1.9 million figure for UVM Medical Center compared to the budget that we have, that would end the year at a $49 million variance. Taking out the mid-year reduction, that brings it down to $29 million, and then that 1% for the kind of uncertainty on exactly where the year end would end brings it down to 9.9. CVMC, same thing, using the projection from the filing. You can see that the variance at the end of the year using that projection would be about 4.2 million, and then the 1% for that uncertainty would be 1.3. The other thing, again, this isn't for necessarily today, but just to give the board some context when we do get to that year-end discussion and exactly where we end the year. Another piece I think that we're going to have to factor into the budget is our Schedule A that we submitted for the transition of Dr. Unger's patients. Did include a piece that would be in 25 and then a piece that's in the 26 budget, because those patients have already started to transfer to the UVM Medical Center. So not necessarily for today, but just to give some kind of a highlight, if you will, on something I think that we're going to need to take into consideration at year end. And when you look at those, when you look at that adjustment for how much of the volume that we submitted in our Schedule A would happen in 25, you can see what that does to the variances. So with that, the UVM Medical Center with the mid-year would be about 22 million, and then when you account for the kind of the 1 year variance, if you will, would be down to 2.8 million. So those are just the quick slides that we thought we'd share with the board today, and open it up to questions, and back to you, Chair Foster.
Thank you. I appreciate the presentation and the overview, and I'll turn to board members for their questions. Start with Member Walsh.
Great. Good morning. Thanks for being here. I want to thank UVMMC and CVMC for being with us and your engagement with the board's guidance and broader affordability goals. As I reviewed these proposals, it was particularly focused on how UVMMC and the network more broadly can ensure that care remains aligned with local needs across all communities. That includes making sure services and patient flow are driven by the mission and medical need at local affiliates, not revenue opportunity. So I'd like to ask a few questions to understand how this reduction, particularly at CVMC, fits into a longer-term strategy to support access, affordability, and community-based care across the system. You're asking for a mid-year reduction. How can you assure us that this is part of a lasting shift toward more affordable pricing?
Member Walsh, is that to CVMC, or do you want both of us to answer? How would you prefer?
I think I was imagining UVMMC responding there.
Thank you. Thank you for the opportunity.
Sure.
I see this proposal, as well as a settlement agreement, as a step towards working together stronger than we have in the past, towards really focused on being certain that all Vermonters get high quality care, safe care, accessible care, and affordability. This mid-year rate adjustment was agreed to in the settlement agreement. And we would have done it even if we didn't have the settlement agreement. I want to make sure you know that we are focused right now on doing our part in Vermont to make sure care is affordable as possible. The reductions that we're implementing here, the amount that we brought forward, will have no impact on access to care that we're currently delivering. It does not project any change in where services would be delivered. The numbers that we have here, we can sustain within the budgets that we've submitted to maintain services as we have them. Next Monday, when we speak at length about our 26 budget, you'll see that our 26 budget, meeting your guidelines and compliance requirements, also does not, as it was submitted, rely on any kind of cuts to patient services as submitted. So this is a step. I see this as part of the settlement agreement, our mid-year adjustment, and our budget for 26, all working together to assure that Vermonters get high quality, safe care as affordable as we can make it.
I appreciate that. And I think the way that I'd organized my questions were these first few are for UVMMC and followed by some for CVMC. So I'd like to just ask Chair Foster, were you wanting to pause in between, or should I just continue through the questions?
I think just continue through the questions.
Okay.
Fine.
Okay, understood. So please bear with me while I try to orient myself around the questions. Again, for Dr. Loeffler, others from UVMMC, what safeguards could you describe for us or provide written safeguards are in place to make sure that future investments or service changes at the medical center don't pull resources or services away from local communities across the network?
I'm trying to make sure I understand that question.
Sure, I can
You're
try to
saying-
clarify.
Okay, I'm sorry.
I can try to clarify. My concern is, quite frankly, with the reduction that's occurring at CVMC. I worry about their ability to remain viable independent of a network. And if they were not independently viable, that my worry would be that they would be less responsive to the needs of their community and function more as a subsidiary of UVMMC. And I'm trying to collaborate with you all today, both organizations, to try to figure out a way that you can help us make sure the state goals are staying prioritized across the health network.
Thank you. I think I understand it. I'll take a shot, but if I miss the
Great.
mark here, please let's have an ongoing conversation.
I appreciate that.
What I can tell you is that UVM Medical Center, as strong as we are, as much as we do, we are unable to take care of every Vermonter who needs hospital care, both within the network and in the state of Vermont. We rely on our partner hospitals in Vermont and New York to take care of appropriate patients locally and close to home. We're building much stronger physician and communication back and forth to keep all of the right patients at CVMC. CVMC takes transfers every day that don't need tertiary care. Same with upstate New York. And on top of that, what I can tell you is across the state of Vermont, UVM Medical Center does not have the bed capacity, the space, the specialists, or the providers to take on patients from across the state who should be getting care locally close to home. Our job going forward, and I think we're doing some of it now, we need to do more, is to make sure that every patient who can stay in Newport, St. Johnsbury, Springfield, Rutland, stays there by, if necessary, telehealth consults, other ways to work with those doctors. We have some good examples right now where the cardiologist that works at Northwest Medical Center gets credentialed through the medical center for ultrasound, for cardiac ultrasounds, so they can provide them in Northwest Medical Center. Our future has to be that every Vermonter gets care as close to home as possible when appropriate, so that we have bed capacity for when very sick Vermonters need us, we have a bed for them. That's our total focus right now at the medical center and the network.
I appreciate that, and I think there's strong alignment with state goals in that regard. What could the board do in partnership with you all to keep affordability and access on track, not just this year through the settlement and through this adjustment, but over the long term?
There's tremendous change in healthcare happening right now in Vermont, nationally, with each of our hospitals. Putting these budgets together this year was extremely challenging. It was important work. I'm proud of the budget that we submitted, but I think the healthcare system in Vermont, not just the medical center, not just the network, but all the hospitals, need some type of, I don't want to call it a glide path, but a couple years to get everything we need to do right. And I realize that butts up against the affordability crisis we have right now. But I'm a big believer in Vermont and working together. I'm a big believer that people working together, like we did over many meetings on the settlement agreement, got to, I hope, a good solution. I do think together with the Green Mountain Care Board, our regulator, our legislator, Vermonters, VOS, and we can actually all work together to have a sustainable system in Vermont. It'll be hard to do it in 2 months with the changes that are going to come from this budget, but I do think I'm a big optimist. I believe in Vermont. I believe we can work together. I should also include our primary commercial insurer, Blue Cross, should be part of that solution. And we have been working with them since May on other ways to partner with them to do a better job for Vermonters on affordability.
The other piece I might add, Member Walsh, is just as the board is starting to contemplate reference-based pricing this year and next year, I think that puts some frame in a criteria, if you will, or definition around affordability that I think it'll be incumbent on us working together to ensure that those targets that are set as we move towards a number that I assume the state and the board is going to be looking for us to achieve, that we do so in a measured way and not make any significant drastic changes in any one year to not impact that access. But I view that as a way to perhaps put some more structure around the affordability discussion. I look forward to working with the board on that model.
Thank you. Would UVMMC support regular reporting that ties its budget and its affiliate hospitals' budgets to service mix and community health needs assessment, so that we could track alignment between community needs and the budget year over year?
So we do a regular community needs assessment as part of our ongoing work. I do believe we can tie that together.
So yes, I'm familiar, and what I'm asking is if you'd support more regular submissions regarding the alignment between community needs and budgets.
We'd be happy to consider that, of course. I want to make sure that I've been involved in community assessments for a long time. They're oftentimes slow to make big changes. They have, like in Chittenden County, it's oftentimes housing, it's mental health issues, it's big issues like that, which oftentimes are slow to move. But of course, we'd be willing to consider ways to work with the board on those issues.
Thank you. Just a couple questions, I believe for Ms. Noonan for CVMC. These proposed rate reductions for short term, but how can you assure the board that this is part of a long-term strategy to remain viable and responsive to your local community needs?
Yeah, thanks for the question, Member Walsh. So we are committed, obviously, to serving the healthcare needs of our community. I do want to point that the rate cuts, in these rate cuts, we're not planning to impact services. I think the board is well aware that we did have some significant impacts in the fall, but these rate cuts do not anticipate further impacts on services. So I just wanted to name that. So we are committed to working across our system and within the network to ensure that we're supporting each other in delivery of care. And a statement that Dr. Loeffler made earlier around the need of that partnership and how it shows up is it's important, I think, for the board to know that CVMC has increased some of its internal services. For an example, our intensive care unit. We have strengthened the type of services we provide there. So we are now taking more patients from outlying hospitals, community critical access hospitals directly to CVMC versus those patients would normally in the past have gone to UVMMC, taking up their ICU space. So that kind of systemness is really, I think, helping UVMMC to keep those beds open for the tertiary quaternary care that they need to provide, and allows us to provide, in this example, intensive care services that are community-based intensive care services to the partners within our region. So We take patients from Gifford, Copley, and within our network from Porter as an example, when they meet that level of intensity that don't require the tertiary quaternary intensity. So I think that's a good example of services we're providing that meets the needs of the community, and again, trying to keep care as close to those where those individuals live as possible.
Thank you. Ms. Noonan, are there any specific regulatory levers, be they budget or reporting or planning, that you believe could help us collectively avoid drifting toward a system-aligned but a community misaligned mix of pricing and service strategies?
I think the work that we're planning to do as a state collaboratively through the Rural Health Redesign Center, the work that we're doing with VOS is intended to look at healthcare delivery across the state. And I think that that work in partnership with the Green Mountain Care Board and AHS will be incredibly powerful in helping us to come together collaboratively, working to ensure that we continue to provide the appropriate healthcare services to Vermonters. So I think a collaborative, open approach is what I would love to see us continue to focus on.
I agree. And part of what I'm trying to do with the questions is ask for your thoughts about what we might be able to do to help with that. And so I appreciate your thoughtfulness. I asked this of UVMMC, but also with you, would you support more regular monitoring, development of a framework that ties the budget, service mix, et cetera, to a local needs assessment?
I think we'd be happy to consider what that would look and feel like, certainly. So I think we should keep that dialogue open and ongoing.
And then just one more question. Can you describe any specific governance, senior leadership, board level at CVMC safeguards that are in place to prevent CVMC from becoming just a high cost affiliate that focuses on highly reimbursed services aligned with network priorities, but loses its local community mission? How do you safeguard against that?
Well, I think each partner within the network is very clear that we're positioned to serve our local communities, and the strength of the network comes from us coming together to look at the region as a whole. So I have no concerns, and I don't think our board has concerns. CVMC's board has concerns that we will not ensure our central mission, which for CVMC is central to our community, caring for a lifetime. We take that pretty seriously. Our patients are our neighbors, they're our family, they're our friends. We have a strong partnership in Central Vermont with other agencies through our Accountable Community for Health. And all of those partnerships coming together, the network working as a system, Central Vermont working with our community partners, is critical to optimizing health outcomes for those we serve. That's not what keeps me up at night, I can tell you, Member Walsh. I think as a Vermonter myself, I'm committed to doing all we can to continue to optimize the health outcomes of those we serve.
I appreciate that, and I hear you and wish for the same, and want to be forward-looking, and at the same time, I believe history and some recent history has shown that it's important to consider how to safeguard local governance and making sure that services are aligned with local community needs, even in the face of network pressures. So I appreciate your response and thoughtfulness. Those are all the questions that I have.
Thank you, Member Walsh. Member Teachout?
Good morning. I have a few questions. One is directed at the University of Vermont Medical Center more specifically, but I'm concerned that this focuses only on the major insurers and how this creates inequity among your patients who are coming to your facility. You know, treating them differently based on their employer and where they receive their insurance. Did you consider that in your proposal?
So, Member Teacher, I'll start at a high level. I may rely on my finance people to help a little more. We did consider that. The vast majority of the overage is in the three major Vermont insurers, Vermont Blue Cross, Cigna, and MVP. It's almost all of the dollars. The dollars to the other insurers are relatively small. And so we believe this was the best path forward for a mid-year adjustment. I don't know if Rick or Judy want to give more detail on the exact amounts, but thank you.
Yeah, I would just echo what Dr. Leffler just stated. And then in terms of being able to obviously adjust, Medicare and Medicaid rates, that those are rates that were just given. So that's why we focused on the payer categories that we did.
I just worry a little bit about, and I'm speaking only of those with commercial insurance, not Medicare or Medicaid, but having two patients with identical conditions just receiving insurance through different employers and having very unequal treatment for their the cost of their care. But this is temporary in nature, at least initially. And I think that leads into my second question. Why are you considering this to be only a temporary change when it appears that you have underlying base charges that are higher than necessary?
You want to take that, Rick?
So I can take that, yeah. So Member Teachout, we have built this into our FY26 budget. So while it's a temporary mid-year rate reduction that goes into the next contract year, when we're sitting in our negotiations with payers, these lower rates will be part of that discussion and is embedded in our budget. So the commercial rates that we have in our FY26 budget do go forward, and a piece of that that's in that budget is this mid-year adjustment.
So just to be very specific about what you're talking about the 3 months at the 215% of ASP carrying over into the FY16 budget?
Correct.
Okay. And then you're required to have the 120 starting on January 1st.
Correct.
And then maybe I didn't fully grasp what you were trying to show in that one slide, I think where you were talking about this, but it appears that even after the 1% kind of reserve that you're saving for, as a buffer, that you still anticipate to be over budget at the end of the year. Is that true?
Based on the projection that we submitted in our budget filing, it does look like we're going to end the year over by $9 million, or after the Dr. Unger budget adjustment is factored in, that it would be about $2 million with that 1% difference.
Okay. And maybe I'm getting my 1% confused, but does that put you into enforcement category or not?
So the enforcement, we would be in that enforcement category just barely by that $2 million with the Younger adjustment.
Okay, thank you. And then I do have a couple questions about your assumptions that were confidential. So if you want to reserve these for later, you can, but there's one specific code that's excluded. And I was curious about what that was and why you were excluding it. And then I did have some questions about your assumptions that had to do with Medicare pricing.
So the one code, so is this then the confidential exhibit A that you're referring
Correct.
to?
Yes.
Let me interject real quick. I think if we're going to get into confidential material, we should probably go into executive session. So I'll ask the witnesses not to answer that. And Ms. Teachout, if we need to do that, we can make a motion after we finish all the public session stuff.
Okay, happy to do that. And then my last question is, do the caps that you're proposing put any of the pharmaceuticals that you're selling where your acquisition cost is higher than the percent reimbursement that you're proposing?
Yeah, we saw that question and that discussion as part of the budget hearings earlier this week. We actually haven't, to my knowledge, I don't know if we've actually done a look back to determine that, but we can follow up with you, Member Teachout, to determine if we have any of those codes that are underwater.
We'll try to have that ready for Monday. We'll do our best. I'm assuming we'll get that question again on Monday, so we'll work to have something for Monday.
Great, thank you. My last question is, sorry to jump around, but back to your chart where you did an annualized basis. Is that weighted or is it just equally distributed among all 12 months?
Just equally distributed.
Okay, thank you. That's it for my questions.
Thank you. Member Merman, any questions?
Yeah, I'll just be brief. So reviewing the settlement agreement, which Mark Henksler reviewed earlier, says after the second quarter of FY25, UVMC will seek a mid-year reduction to its FY25 commercial rate growth if necessary to ensure compliance with the GMCB FY25's budget order. Does this proposal meet that obligation?
So Member Merman, first off, I will say that as we were winding down the second quarter, there was legislation that was in front of Vermont House and Senate that ended up being Act 55. And it was possible that was going to start as soon as July 1st, which may have meant that we needed no adjustment. It might have fixed all of the issues itself. And so we delayed submitting this until we understood that it wasn't going to start till January, which was a very last minute thing. I can tell you that in the ongoing discussions that we were having, working towards a settlement agreement, my understanding, I know what's written, I know what the law is, but my understanding was that in good faith, we would come forward this year before the year was over to make an adjustment to try to get as close as we reasonably could to the end of the year. I understand that how it's written looks like Rick just said we could still be a couple $1 million off on that. In good faith, this was an effort to have a compliant budget from last year.
Okay, so there's two components there. There's the timing,
yes,
and then there's the budget compliance. So I understand that from the timing standpoint, there was something that occurred. From the budget compliance standpoint, does this fulfill UVM's obligation? Do you believe this fulfills UVM obligation in that settlement agreement?
So the numbers have still been adjusting, but as I understand it, as of yesterday, we might end up 2 million over. And the Green Mountain Care Board has the ability to enforce that 2 million return if necessary. It seemed as we were building this, it was better not to overshoot than to undershoot. And we tried to get very close. And I'll just say $2 million on a $2 billion budget feels close to me with this adjustment. And if we are over by $2 million, you still have the full right of enforcement to correct if necessary. So I'm not trying to avoid your question. I'm trying to answer how we got here and what the proposal was. I guess by the letter of the law, it doesn't exactly meet what was written, but I do believe it meets the spirit of what we're working on.
Okay. What's your projected operating margin with this adjustment that you're proposing to do?
Is it 2.7, Rick?
Yeah, so I'll just defer to Judy. I don't know if you've got the budget up or not.
I do not have it up factoring in this proposed adjustment, but we will certainly provide that for you.
Okay. And do you know what the margin is on Unger's practice shift of that $7 million of revenue?
We will look back at our Schedule A. The intent for that was to be able to allow care for those patients without disruption and without significant burden to healthcare payers and the overall Vermont healthcare system.
Mm-hmm. Okay, if you could get back to me with that margin, that would be great. And that's all the questions I have now. Thank you.
Just a couple for UVM. First, is this proposal retroactive to August 1st?
Rick,
Yeah, that was our proposal, was to get this to get the rate changes in on August 1st. So if depending on this ruling, we can go back and update the numbers. What that will change is in the Schedule A, those percentages are going to need to change, because we're going to have to make up for the fact that we didn't implement on August 1st.
Got it. And then just in terms of, and I appreciate Dr. Leffler, what you said about the spirit and how you're trying to comply and all of that. But the one number that would be helpful for me is if you can calculate it, not on the fly here, but the delta between the letter of the settlement agreement and this proposal, because there's a couple components to it. One is it doesn't include Medicare or Medicaid, well, the total overage for NPR, at least as projected. And then two, some of it is being applied for next year. So there's two pieces to it. And I just want to understand the dollar value of what's being proposed vis-a-vis the settlement. And then the other question I had is if the board doesn't pursue the full settlement terms, UVM would get the benefit of the 1% buffer, whereas the settlement terms would remove that 1% buffer. So there'd be another delta on how much commercial rate relief would be achieved, right? And then third, it appears that if it's just on the drugs, that will happen in 2026 anyway, whereas if this were applied to non-drugs, it'd be a deeper reduction in cost for Vermont commercial payers, because they'd get the non-drugs and then they'd get the drugs in 2026. I don't think there's, I guess I'll stop there, but just observe that. That's really all I wanted to know was if you could give us that information. And then just to clarify, I think Dr. Leffler, in your intro remarks, you said something along like this proposal will preserve Medicare rates if we do it just as to commercial. But I believe that when we do an enforcement include the total NPR, it doesn't actually change anything about the Medicare reimbursement rates. We're effectively just using the total budget overage to benefit commercial. Your Medicare rates won't change at all, correct?
it won't change our Medicare rates. It does change the total Medicare reimbursement that we keep in a year.
Right. It's effectively actually a reverse cost shift.
Yes, I agree with that.
And then the Medicaid changes, I think that you alluded to, the changes coming in Medicaid, those are scheduled to start in 2027. Do I have that right?
Most of them start in 27, yes. And the ACA starts in 1/1/26.
Let's hope it doesn't.
I agree.
Okay, no other questions. Thank you, Dr. Leffler and Ms. Noonan and your teams for your presentation and for the submission. Thank you very much.
Thank you.
I'll turn to the healthcare advocate for any questions or comments they have.
Good morning, Mr. Chair, members of the board and hospitals. Thanks for this opportunity. Just a couple of questions. First, curiosity, I'm truly trying to understand the lay of the land here. Can you tell me what impact, if any, the existence of the liaison has in this proposal or in the background leading up to this proposal, if any?
I have not discussed this proposal with the liaison. This proposal was formulated by us to comply with the settlement agreement as best we were able to.
Right. Okay.
Rick, go ahead, Rick.
I was.
So the proposal was shared, and in terms of just the work with the liaison more generally, the work that we're doing with the liaison and his team, I think, has been excellent, and they've been very helpful to kind of highlight things, not only in terms of our operations, but also helping us as we prepare for our budget hearing and being able to truly be able to kind of explain and our numbers, I think, have been very, very helpful. It's gone very, very well.
Okay, thank you. I was sort of going in a similar place. I think board members started to go in this direction. Curious why you decided to apply this reduction only to the ASP, the ASP for medications and not a broader unit cost reduction.
My understanding from the finance team is it was simple to do this way. We had to do this work anyway to get ready for January 1st. So it aligned with work that already needed to be done, and it was simple to implement.
Okay, that makes some sense. I guess this is more of a comment than anything. Just want to sort of recognize the irony of this moment. There was a proposal to start the hospital administered ASP cap earlier. It was in the legislature. It was met with very strong pushback from the hospitals, and so to have this proposal land as a way to achieve the budget that you agreed to is I just have to note it.
Yeah.
Even
Mike, what I would say is,
history.
yeah, I had a chance to testify on the bill. I will admit I had significant concerns with the bill. The start date was not one of them. I do not think that the network lobbied anyone to have the start date change, but we did have concerns with the bill. I will say that.
Yeah. Okay. Thank you.
Great, thank you. I'll take public comment via the raise the hand function. Okay, seeing none. Sorry, Mr. Leclerc.
Sorry, I was waiting. I have 5 things. Is UVM telling patients when they're scheduled for surgeries to schedule their care at outpatient clinics in advance? We have people getting surgeries and we're booked out for 6 weeks. That's not efficient. So when someone gets a surgery, they can't get in. It's not good. Second, why would I, as a Blue Cross member, pay more for my PT at UVM than a UVM employee? I think they fixed it with this adjustment. I checked on their website with the price transparency, but we were, all of us, the public, teachers and state employees, paying more than they were. 3, please ask Blue Cross confidentially which CPT codes they're billing more than usual compared to last year and what the price increase was. Fourth actually, please ask how much money UVM has sent to the New York hospitals for this fiscal year, and if they will send more money in 26. The answer better be 0. I do not want any Vermont money getting transferred to New York. And just lastly, as a non-lawyer, August 1st is not a mid-year adjustment. It's late. That's my comment. Thank you.
Thank you for your comments, Mr. Leclerc. Ms. Keller? Here, I might be able to unmute you if that's let me see if I can.
I'm sorry, I'm not used to Microsoft Teams. Can you hear me now, everybody?
We can, yes. Thanks for being here.
Thank you very much. Very interesting conversation, and thank you all for the attention to detail that you're paying to all of this. I sent a communication yesterday to all of you about some announcements that were made last week by UVMMC regarding changes in their budget. I did not know whether that would be applicable to this meeting or it's applicable to next week's meeting. But I would ask you please to read this because, as you know, I had amicus status on the now withdrawn application for the renovation of the McClure garage. And I appreciate that that was granted to me. My statement yesterday that was sent to you yesterday is about a plan they have to defer maintenance on the garage as a way of cost savings. As we all learned, because you required them to disclose the engineering consulting reports that they had received, you required them to disclose them to us all. We discovered and learned that that their most recent consulting engineer said that a $7 million expenditure over the next 20 years would give 20 years of life to the McClure garage versus leaving it to fall to ruin, which deferred maintenance is doing, leaving it to fall to ruin, resulting in their applying for a CON for $38 million or more to replace the McClure garage. Penny wise, pound foolish. Penny wise, pound foolish. Obvious on its face to anybody trying to save money, as they say they are trying to do for commercial and private payers and government payers. It is just kind of beyond belief to me that they are presenting deferred maintenance as a way to save us all, to save this healthcare system. So please pay very close attention to this, as you did during that CON application process. And I appreciate very much your attention to this. Thank you.
Thank you very much, Ms. Keller. We appreciate you observing and commenting and helping us think about these problems and for taking the time to be here. We really appreciate that. Some of these issues I think that you and Mr. Leclerc brought up will probably be more relevant to the hospital budget process, which we have a hearing for UVM next week. I think some of this will come up. Any other public comment at this time? Representative Alyssa Black.
Hi, thank you. And I'm sorry, I'm actually on a computer that doesn't have a camera. So since the mid-year adjustment was part of the settlement that was approved earlier in this year, I'm wondering if UVM Medical Center could comment for the public on the distribution of the settlement and what's been achieved so far in that.
Sure. Thank you for the question, Chair Black. I'll turn it to Dr. Leffler, and I have some information I can provide as well, but I'll start with Dr. Leffler.
Thank you for the question, Representative Black. So we have settled with Blue Cross Blue Shield. Those dollars have been paid out. We've been working diligently with AHS, the Green Mountain Care Board, our lawyers to figure out how to distribute the primary care dollars. I saw an email late on yesterday. We think we have a path forward for that. I don't really want to comment until it's done, but we are working very hard to make sure there is a mechanism to pay out the primary care dollars. So we should be close to an announcement on that. It will happen.
I can add that was exactly my understanding. I know that my team sent me an email last night actually working on this as well. So I know the teams are working on it. I presume in the next couple weeks, we'll have made a little bit more progress. And then the other comment I would have, Chair Black, is on the $15 million fund for the liaison team and the potential consultants. There has not yet been an RFP issued, and I know there's discussions going on about limiting, if appropriate, the amount of the 15 million that is used on consultants and considering whether or not we can retain some of it for other purposes consistent with the settlement agreement. Nothing's been decided on that, but I know that's part of the discussions going on, as that was a cap, not a required amount.
Thank you so much.
Thank you, and thank you for being here. Mr. Maloney.
Hello, everyone. My name is, can you guys hear me okay?
Yes, sir.
Just check. Okay. I just wanted to open it up to UVM Medical Center and Central Vermont Medical Center. I wanted to ask explicitly, with the insurance reductions, the commercial insurance reductions, do we know that the impact do we know of the impact that this will have on patients who hold those types of insurance right now, or is it too early to say? I just wanted to get a better indication on that front.
We know this will decrease the cost of care to our commercial insurers that are impacted by this. They will spend less money between August 1st and January, so that decreases their overall expenses, which should relate back to ratepayers.
Thank you, Dr. Leffler, and thank you for the question, Mr. Maloney. The live media question is a new twist. I haven't quite thought through how to handle yet, but thank you for the question, and thank you, Dr. Leffler, for providing the response. Any other public comment? Well, thank you to the UVM and CVMC teams, and we will take a recess. And we have, I think, the Brattleboro hearing first this afternoon. Forget the time, but it's on the schedule. So we'll take a recess from the hearing. I'm sorry, one more question or public comment. Miss Martha Lang.
Can you hear me?
Yes.
Okay, yes. My name is Martha Lang, and I live on Colchester Avenue, directly across the McClure Garage. When I first heard about UVMC's attempts to tear it down, I asked to pay for a private engineering study myself, and they denied me that opportunity. I'm very concerned that with this budget, that they will continue to let the garage deteriorate. You must hold them responsible for maintaining to a minimum standard the garage. It's not unreasonable. I'm still more than willing to pay for an engineering study of the McClure Garage to get at the truth. I hope that you will hold them to a minimum standard to prevent that garage. That to build a new garage when the one they have there now, that's wasteful spending. You're talking tens of millions of dollars. So please hold them responsible. And thank you for this opportunity to speak. I appreciate all your hard work. I really do. Thank you so much.
Thank you. And thank you for taking the time to be here. Okay, we will take a recess and the board will come back at 12:15 for the Brattleboro hearing on their budget and then 2:45 for Rutland. And we will recess till then. Thank you, everyone.